Hello everyone, we are from Group 8A and this is our pediatric case presentation. The patient is a 3-year-old boy with a BMI of 15.5 in the median percentile. The chief complaint is worsening cough associated with post-cough vomiting throughout the day and affecting his sleep. His HPI prior to admissions were runny nose, fever, rapid breathing, reduced oral intake, and this is his 5th hospitalization due to respiratory problem. For his family history, his mother has history of allergic rhinitis, while her younger brother was recently admitted due to bronchiolitis. For his parents' social history, his father is smoking although he claims to be not smoking in the house.
Next, drug-related problems. Firstly, non-adherence to MDI budesonide. According to past medication history, patient had missed dose for MDI budesonide and this could be the cause of acute exacerbation of bronchial asthma (AEBA) in this patient. For the management, patient education and counseling on importance of adherence towards MDI budesonide is required, especially for his parents, and we can monitor the frequency of AEBA in this patient. Secondly, inadequate inhaler technique. Wrong inhaler technique was noted, and this could reduce effectiveness of drug therapy and cause poor patient outcome. To manage it, patient education and counseling on correct inhaler technique and its importance for his parents is required. And we can also monitor the frequency of ABA in this patient. Thirdly, discontinuation of prednisolone therapy starting from day 3. Oral prednisolone 1 to 2 mg per kg per day for 3 to 5 days is the recommended treatment for mild and moderate AEBA. However, oral prednisolone was given in the patient on day 2 only. For the management, oral prednisolone therapy should be continued on day 3 and 4 to complete the prescribed 3-day course. We can monitor whether signs and symptoms of AEBA is resolved in this patient. Lastly, initiation of loratadine therapy on day 6. Loratadine is usually indicated for allergic rhinitis and urticaria. However, signs and symptoms of both medical conditions were not detected in this patient. Hence, we can review the use of loratadine in the patient and discontinue loratadine if there is no clear indication.
So the possible diagnosis of this patient is firstly, acute exacerbation of bronchial asthma secondary to URTI, which can be evident on the first day, which is increased respiratory rate, decreased oxygen saturation level, and increased heart rate. The next diagnosis is pneumonia, which can be evident through his high fever, having chesty cough, and also having haziness in his chest X-ray.
For the management of acute exacerbation of bronchial asthma, on day 1, the patient has increased respiratory rate, decreased oxygen saturation level, and increased heart rate. The management given to the patient was nebulized salbutamol on day 1 and day 2. It was appropriate, but the dose is not stated. According to a pediatric protocol, the dose should be 5 mg per dose. Next, the patient also received oral prednisolone 15 mg OD on day 2. The dose is appropriate, but it was only given for 1 day. According to a pediatric protocol, oral prednisolone should be given for 3 to 5 days. Next, for oxygen therapy, the patient received appropriate management through nasal prong oxygen.
Next is the recommended management for pneumonia, as these are the evidences. And as according to the National Antibiotic Guideline and Pediatrics Protocol 4th edition, the first line is IV benzopenicillin, and this is appropriate dose on day 2. And on day 4, it is switch therapy from IV to oral, which is appropriate also because the patient is getting stabilized. However, the dose is a bit higher than the recommended dose from FUKM and BNF, which is 125 mg QID or up to 164 mg. Next, after 12 hours on day 4, it is changed from IV cefuroxime to 128 mg TDS from the syrup penicillin because the patient is getting worse. However, according to the Pediatrics Protocol for Edition, the second line is used when there are no signs of recovery or patient remain toxic and ill for 48 to 72 hours. However, in our patient, it's only been 12 hours. And dose is also inappropriate because according to the NAG, the suggested dose supposed to be in this patient is 436 mg to 655 mg. And at day 7, it is changed, the dose is increased according to the suggested dose. After the chest X-ray revealed that the lung is getting worse. On day 9, the patient is discharged with syrup cefuroxime 195 mg BD for 1 month. Okay, firstly, the dosage is appropriate as according to the FUKM. However, the frequency is a bit inappropriate because according to MACPAC's Paediatric Pulmonary, the use of antibiotics should be 7 to 10 days duration, and it will be longer in presence of complications such as emphysema, which is absent in this patient. And secondly, the side effects of the use of cefuroxime more than 14 days is diarrhea. So it should be avoided in this patient.
For the management of fever, syrup paracetamol 195 mg QID was given to the patient from day 1 to day 9. The dose is slightly higher compared to the suggestion in MIMS and BNF for children, but it is appropriate according to the PPUCAM formulary. Besides, suppository paracetamol 250 mg was given to the patient on day 1 as well. Although the dose is appropriate, but it was given to a patient in less than 4 hours of interval from the last dose of syrup paracetamol, and it will cause overdose in the patient. Therefore, we will suggest to perform tepid sponging in addition to the oral paracetamol given to the patient to lower the temperature in the patient. However, after 4 hours, if the patient's temperature is still high, then we can suggest to give suppository paracetamol to the patient.
For the monitoring parameter for the asthma, for the efficacy, we can monitor sign and symptom of bronchial asthma exacerbation. And also for the safety, we can monitor side effect of prednisolone. For the pneumonia, for the efficacy, we can monitor sign and symptom of pneumonia such as fever, cough, and weight loss. And for the safety, we can also monitor side effect of the cefuroxime itself. Okay, so for the other general monitoring parameters, you can monitor sign infection due to URTI and also pneumonia. Test as a result can also be used to determine the extent or location of the infection. We can also monitor CNS result. For the safety, we can monitor input and output chart and also assess hydration status because patient is at increased risk for dehydration. We can also monitor patient weight because patient had poor oral intake. Okay, next for the pharmacist intervention, we can counsel the caretaker on proper inhaler technique and also proper use of drug delivery device such as pacer and also face mask. We can also encourage adherence to medication because non-adherence will lead to the higher risk of hospitalization. We can also counsel patient on common side effect of inhaled corticosteroid. As the father is a smoker, we can advise for the father to stop smoking. We can also educate on the caretaker on proper and correct use of antibiotic by finishing the entire course of the treatment. We can also encourage the usage of shrink to promote the dosing accuracy in this patient.